Welcome to this explainer. Look, if you're gearing up for your MRCOG exams or you're just looking to sharpen your clinical instincts on the labor ward, you are in exactly the right place. Today, we're doing a rigorous, deep dive into the RCOG Green-top Guideline on shoulder dystocia. This is an absolutely essential protocol for all MRCOG candidates and a vital skill set for every single obstetrician.
All right, let's get right into our clinical pathway for today. We'll kick things off with core definitions and then move chronologically through prediction, acute first-line management, advanced internal maneuvers, aftercare, and finally, medical legal risk management and training.
Starting with Section 1, getting our background and core definitions nailed down.
Now, I really want to emphasize that everything we cover in this explainer comes straight from the absolute gold standard, the Royal College of Obstetricians and Gynecologists Green-top Guideline No. 42. This document dictates the standard of care across our maternity units.
So, what's the crucial takeaway for your exams and your actual practice? It's the objective definition of shoulder dystocia. Sure, we know it happens when the fetal shoulder impacts on the maternal symphysis or sacral promontory, but look at the objective criteria here. It's not just a subjective, oh, this feels a bit difficult. It is a measurable, definitive prolongation of more than 60 seconds from the delivery of the head to the delivery of the body. You have to rely on that objective timeline, not just your gut feeling.
Just to put the scale of this into perspective, shoulder dystocia complicates roughly 0.58 to 0.70% of vaginal deliveries. So, yeah, it's rare. You're not going to see it every single shift. But when it does happen, the stakes for perinatal morbidity and mortality are incredibly high.
Moving on to Section 2, Prediction and Prevention. How do we anticipate this?
As an MRCRG candidate, you absolutely have to memorize these risk factors. Notice how they're neatly split up here into pre-labor factors like maternal diabetes and macrosomia, and intrapartum factors, things like oxytocin augmentation or an assisted vaginal delivery. But while you really need to know this inside and out for the exam, keep in mind that their actual clinical utility on the ground, it's honestly quite limited.
And here is a totally surprising clinical reality that perfectly illustrates those limitations. Statistical modeling shows us that risk factors actually have a super low positive predictive value. Think about this. 48% of these emergencies occur in infants weighing less than 4 kilograms. Basically, risk models fail to prevent the vast majority of cases. The bottom line, you must always be on high alert and ready to act completely regardless of the estimated fetal weight or the maternal history.
Okay, let's get into Section 3, Diagnosis and First-Line Management, the acute phase.
In the room, recognition has got to be instantaneous. You're watching that perineum like a hawk for the classic visual signs. You might notice difficulty delivering the face, or see that classic turtleneck sign where the head retracts tightly back against the vulva. You might also see the fetal head fail to restitute, or just notice that the shoulders aren't descending with routine axial traction.
I really have to pause right here and emphasize an absolute clinical red flag. Once you diagnose shoulder dystocia, you must never apply downward traction, and you absolutely must never use fundal pressure. It's a huge no-go. Cadaver studies and clinical data strictly show that lateral or downward traction directly causes severe nerve avulsions, which leads to brachial plexus injuries. And fundal pressure, that just worsens the impaction and brings a very real, terrifying risk of uterine rupture. Stick to routine axial traction only when you're assessing if a maneuver has actually worked.
The second this happens, your rhythm needs to be fast, algorithmic, and totally decisive. Step 1, call for help immediately. You're going to need an experienced obstetrician, midwifery support, a neonatal team, and an anesthetist. Step 2, clearly state the emergency out loud to the room. Literally say, this is shoulder dystocia. Just getting that out there early drastically improves team performance. And step 3, get the mother to stop pushing immediately to prevent wedging those shoulders in any further.
Right, next up, you immediately deploy your first-line mechanical interventions. You're going to start with the McRoberts maneuver, flattening the bed and hyperflexing the maternal hips. It's simple, it's fast, it straightens out the lumbosacral angle, and honestly, it boasts success rates up to 90%. Now, if that doesn't immediately free the shoulder, you pair it with suprapubic pressure. Have an assistant apply pressure downward and laterally. This physically reduces the fetal bisacromial diameter and helps rotate that anterior shoulder right into the wider oblique pelvic diameter.
Let's escalate to Section 4, Internal and Third-Line Maneuvers.
If first line fails, you're going to need to gain access to the most spacious part of the pelvis, the sacral hollow.
Sometimes, you might even need to cut an episiotomy here just to physically get your entire hand inside. At this point, you have a choice based on your training and the clinical picture. You can use internal rotational maneuvers, like Woods or Rubin, where you apply pressure on the posterior shoulder to rotate it. Or you can try delivering the posterior arm by grasping the fetal wrist and pulling it out in a straight line. Delivering the arm dramatically reduces the shoulder diameter, which is great, but be aware, it carries a 2 to 12% risk of a humerus fracture.
Now, the all-fours position is an incredibly effective alternative here, especially if you're out in a community setting or if you're dealing with a slim, mobile patient who doesn't have an epidural. Literally having the mother flip onto her hands and knees completely shifts the pelvic dimensions. It's actually highly effective, with some studies showing success rates hitting 83%.
But what about those completely refractory cases, those absolute nightmare scenarios? Well, that's where third-line interventions come in. We're talking about cledotomy to deliberately break the fetal clavicle, symphysiotomy to divide the maternal pubic ligament, or the Zavanelli maneuver, which is literally pushing the fetal head back into the vagina to do an emergency C-section. Let me be perfectly clear, you use these with extreme caution. They carry incredibly high risks of maternal morbidity and poor neonatal outcomes. These are strictly absolute last resorts.
Moving to Section 5, Maternal and Fetal Aftercare.
Once the baby is finally delivered, you can't just relax. You have to proactively manage the maternal complications. We're looking at an 11% incidence of postpartum hemorrhage and a 3.8% risk of severe third or fourth degree perineal tears. At the exact same time, you need a neonatal clinician to thoroughly examine the infant. They need to be checking specifically for fractures and for brachial plexus injuries, which can complicate up to 16% of these deliveries and is honestly one of the most critical neonatal outcomes we face.
And finally, Section 6, Risk Management and Training, Protecting Our Patients and Ourselves.
You need to know that neonatal brachial plexus injury is the third most litigated obstetric complication in the UK. Because of that, your documentation has to be flawless. The NHS Litigation Authority has pointed out that nearly half of litigated injuries are linked to substandard care. So you must document the exact time intervals, the precise position of the anterior shoulder at the time of dystocia, the specific sequence and timing of every maneuver you used, and the cord blood gases. Honestly, using a structured pro forma here is highly recommended to make sure you don't miss a single detail.
The Green-top Guideline is crystal clear on this next point. Just having theoretical knowledge in your head is not enough. Annual, multi-professional, high-fidelity simulation training is flat-out mandatory for all maternity staff. Practicing on mannequins is the proven way to keep delivery skills sharp, improve teamwork, and crucially, stop us from using excessive traction forces when the adrenaline is pumping.
So as you keep prepping for your MRCOG exams and before you step onto the labor ward for your very next shift, I want to leave you with this final critical thought. When that fetal head delivers, restitution fails, and those 60 seconds start ticking, are you and your team truly ready to act without hesitation?